Good afternoon. The committee will come to order. We're here to receive testimony today on 3 bills that will improve health care delivery across Native communities. First bill I want to highlight is S2098. This is a land transfer bill that I introduced with Senator Sullivan. It would transfer approximately 3.4 acres of federal land in Anchorage for the IHS to the South Central Foundation. This is an Alaska Native Tribal Health Organization that already provides health care to IHS beneficiaries under a self-governance compact. On this site, SCF operates the Quiana Clubhouse, which serves adults over 21 with serious mental health needs through culturally grounded behavioral health services. SCF is ready to expand the facility and offer more intensive outpatient programming. We heard a lot about it this morning, but they cannot move forward until they own the property, so this bill would make that possible. The other 2 bills before us were introduced by our colleague, Senator Rounds, and they focus on fixing real challenges. I want to thank Senator Rounds for advancing these and really prioritizing these issues. Tribal members face so many issues with purchased and referred care, PRC. The PRC allows the Indian Health Service to purchase care from private providers for tribal members when the needed care is not available through IHS. S1055, the Indian Health Service's Emergency Claims Parity Act, would give patients more time to notify the PRC after receiving emergency care from 72 hours to 15 days. Right now, many tribal members are expected to meet a tight reporting deadline while dealing with a medical emergency, and this bill would bring fairness and common sense to that process. S699, the Purchased and Referred Care Improvement Act of 2025, addresses reimbursement delays for the purchased and referred care. When IHS payments to non-IHS providers are late, patients can end up facing collections or find themselves saddled with unexpected medical debt. S699 strengthens liability protections and requires procedures to be developed for IHS to reimburse patients who paid out of pocket for PRC-approved care. I'd like to acknowledge and thank our witnesses for being here. It is very important that we hear from the IHS on these bills, so thank you. I'm also grateful to Vice President Ross and Council Member Seymour for traveling from Alaska and Washington State to share their testimony. We appreciate that. We do have one more vote after this series, so we're going to be popping in and out, and committee meetings as well, so we apologize for a little bit of the disruption, but we're making good progress, and I now turn to my colleague and the ranking member, Schatz. The Vice Chairman, excuse me.
Thank you, Chairman Murkowski, for convening today's hearing on legislation to improve health services and facilities for Native communities. The federal government has a fundamental trust responsibility to provide health care to American Indians, Native Hawaiians, and Alaska Natives. This obligation is not and cannot be an aspiration. It is a duty grounded in federal laws, treaties, and the federal government's own promises. When it fails, Native families pay the price. And yet lofty promises from Secretary Kennedy to, quote, protect healthcare access and strengthen delivery systems across Indian country have not come to fruition. We've seen the opposite. Tribes and their advocates have consistently raised alarms about HHS's office closures, budget cuts, and new administrative processes that delay healthcare delivery. I've sent letters to Secretary Kennedy seeking basic information that tribes and the Native Hawaiian community need to know. In these letters, the chair and I asked about reorganization and reduction in force plans. We asked about IHS staffing levels, hiring freezes, and the practical impact of delays in filling vacancies. And I asked about the changes to grant review processes and what those changes mean for tribal and urban Indian health programs trying to plan a year or even a month ahead. This committee even held an oversight hearing last May highlighting all HHS programs serving Native communities and the agency's obligations. But we have struggled to get timely, straightforward information. Responses often come late, are often incomplete, and use carefully worded generalities rather than providing real answers. Let me be clear, it should not take repeated letters to get plain English explanations of what is changing at HHS, why it's changing, and how and whether tribes were consulted before decisions were made. This is not an unreasonable ask, it's not even a partisan ask. It is Congress doing its job and the tribes demanding the respect that they are owed. Tribes need a federal partner that provides concrete information, answers questions, and treats consultation as a real process, not a box-checking exercise. The consequence of this failure to communicate are not abstract. IHS civilian workforce is at a 10-year low. Clinics struggle to operate without staff, and patients cannot access the care that they need. Tribes can't reach agency staff for solutions to urgent problems that they face. So going forward, I hope IHS will agree to come prepared to talk to our committee and answer questions about basic matters of accountability and real steps that the agency is taking to improve access to health care. And while I'm glad that IHS announced an effort to begin a new hiring initiative for medical professionals, the details are scarce again. The agency press release vaguely cited a comprehensive workforce plan, but Congress has not seen it. And the tribes were not consulted. And so my message today is straightforward. HHS has to begin to restore a basic level of trust by sharing facts, timelines, and clear commitments to Congress and to Indian country. Tribes will keep advocating for their citizens as they always have. We in Congress will keep doing our job, but the agency needs to meet these actions by doing theirs with transparency and accountability. I want to thank you for convening this meeting and thank the witnesses.
Thank you, Vice Chair. Senator Rounds, did you care to make an opening statement?
Madam Chair, if you would allow, I would appreciate
Please, go ahead.
that. Thank you. First of all, thank you to Chairman Murkowski and Vice Chairman Schatz for this hearing today. The Purchased and Referred Care Program is an important part of how health care is supposed to be delivered for tribal members who have no access to direct care at an IHS facility. However, tribal members in my home state of South Dakota routinely encounter obstacles when attempting to seek payment for health care services outside of an IHS facility. Under current law, most tribal members receiving emergency care outside of the IHS network must report that care within 72 hours, or IHS will not provide reimbursement for their care. This is perhaps one of the shortest windows to submit emergency claims out of any healthcare system in the world. My bill, S-105, the Indian Health Service Emergency Claims Parity Act, would fix this by moving the emergency notification requirements of IHS's PRC program from 72 hours to 15 days. This will allow patients the necessary time to seek care at the closest facility that can adequately address their emergency needs without worrying that the IHS won't reimburse costs. However, even properly submitted PRC claims may not be paid in a timely manner. A 2020 report by the Department of Health and Human Services found that between October of 2013 and June of 2016, an estimated 32,000 claims were not paid within a 30-day time period during this time frame. My bill, S-699, the Purchased and Referred Care Improvement Act of 2025, would help fix this. It would require IHS to develop procedures to reimburse beneficiaries for approved PRC services within 30 days and make sure that IHS addresses any unintended costs for beneficiaries with approved PRC claims. It would also allow a beneficiary to submit documentation to the agency electronically or at a service unit. And finally, it would strengthen the liability provisions of the Indian Health Care Improvement Act, making it clear beneficiaries with approved PRC claims are protected from outside providers and third parties attempting to collect wrongfully charged debt. Combined, these bills would provide needed reforms to IHS's PRC program, and I ask for my colleagues' support as we work towards a markup. And once again, Madam Chairman, I thank you and the Vice Chair for your privilege of allowing me to speak at this time.
Absolutely. And again, Senator Rounds, thank you for your leadership on these issues. We'll now turn to the witnesses. We will first hear from the Honorable Darrell LaRoche. He is the Deputy Director for Management Operations at IHS here in Washington, D.C. He will be followed by the Honorable Dana Seymour from Inchilum, the interim district representative and Health and Human Services chair at the Colville Tribal Business Council, the Confederated Tribes of the Colville Reservation out in Washington State, and Ms. Leandra Ross. Leandra is the Vice President of Executive and Tribal Services at South Central Foundation in Anchorage, Alaska. I will just remind our witnesses that we do have your full written testimony, so we would encourage you to try to keep your your verbal statements to about 5 minutes, and then we'll have an opportunity for questions following that. So, Mr. LaRoche, please, with your testimony, please, and thank you.
Good afternoon, Chair Murkowski, Vice Chairman Schatz, and members of the committee. I'm Darrell LaRoche. I'm the Deputy Director for Management Operations at the Indian Health Service. Thank you for the opportunity to provide testimony on S2098, the South Central Foundation Land Transfer Act of 2025, S1055, the Indian Health Service Emergency Claims Parity Act, and S699, the Purchase and Referred Care Improvement Act of 2025. If I may restate the mission of the Indian Health Service, which is to raise the physical, mental, social, and spiritual health of American Indians and Alaska Natives to the highest level. This mission is carried out in partnership with American Indian and Alaska Native communities. The first bill before the committee, S2098, the South Central Foundation Land Transfer Act of 2025, would authorize the Secretary of Health and Human Services to transfer certain land in Anchorage, Alaska to the South Central Foundation by warranty deed without requiring consideration to the federal government. The bill would also require the conveyance to be completed as soon as practicable, but no later than 2 years after enactment. Additional details are included in my written statement. As you know, Chair Murkowski and members of the committee, Congress has considered similar legislation in previous years that mandated land transfers by warranty deed rather than by quitclaim deed, and the department has the same concerns with S2098. As noted in my written testimony, HHS has identified certain preferences, and with those concerns in mind, the department supports the purpose of the bill to convey the property to South Central Foundation. S1055 and S699 both relate to the Indian Health Service Purchase Referred Care Program, the administration and the department's goals to improve health outcomes for American families and protect patients from medical debt. Therefore, I think it is very important to note that patients are not liable for PRC costs under Section 222 of the Indian Healthcare Improvement Act, and patients should not be forced into collections because of the unpaid medical bills. The PRC Improvement Act seeks to address liability for payment of charges or costs associated with the provision of PRC services. It would require the Secretary of HHS to notify a PRC provider and any patient who receives PRC by IHS that the patient is not liable to any provider, debt collector, or any other persons for the payment of any charges or costs associated with the provision of the PRC services. It would further require the Secretary through IHS and in consultation with Indian tribes to establish and implement procedures to allow a patient that paid out of pocket for PRC authorized by IHS to be reimbursed by the IHS for that payment when the patient submits documentation to the IHS consistent with the procedures established under the PRC Improvement Act. Simply put, patients should not be expected to pay out of pocket for PRC authorized services consistent with the patient protections in Section 222. However, if a patient chooses to pay in anticipation of a reimbursement under the new subsection D of the PRC Improvement Act, the patient should be cautious not to pay before alternate resources are exhausted or in excess of the PRC rates. Thus, as drafted, the bill may cause additional uncertainty for patients seeking care. S1055, the IHS Emergency Claims Parity Act, seeks to modify the notification requirements for emergency PRC services. The current timeframe for non-elderly or disabled individuals notifications must be within 72 hours per current PRC regulation. The only concern with the bill is flexibility. If there's ever a need to change the timeframes for notification of treatment or admissions to more than 15 days, such would need to be an amendment to a statutory limitation if the bill were to be passed by Congress and signed into law. All things considered, the department shares the same goals as the drafter to improve PRC program, protect patients from medical debt, and ensure American Indians and Alaska Natives throughout Indian country have access to high quality and affordable care. We look forward to continuing our work with Congress on these bills, and as always, welcome the opportunity to provide technical assistance as requested by the committee or its members. Thank you again for this opportunity to testify.
Thank you, Mr. LaRoche. We next turn to Dana Seymour. Welcome.
Good afternoon, Chair Murkowski, Vice Chairman Schatz, and members of the committee. My name is Dana Seymour, and I'm a member of the Colville Business Council, the governing body of the Colville Tribes. Thank you for inviting me to testify on the Purchase and Referred Care Improvement Act. Purchase and Referred Care, or PRC, is a program where IHS beneficiaries receive care from private non-IHS health providers when IHS is unable to provide the care at its own facilities. As discussed in more detail in my written statement, for years, IHS mismanaged the Purchase Referred Care program at the Colville Service Unit. Our local IHS personnel, most of whom are Colville tribal members, went to great efforts to try to get PRC services for our tribal members and otherwise make the PRC program workable. The IHS Portland area office, however, would impose new obstacles at every turn. Addressing PRC was the main reason that on October 1st, 2025, we contracted all IHS functions under the Indian Self-Determination Education Assistance Act. From 2017 to 2022, the IHS Portland area office administered the PRC program at the Colville Service Unit. During this time, the PRC program was administered so poorly that we can trace it to deaths in our community. IHS required on an annual basis our members to produce utility bills, certificates of Indian blood, other proof of tribal enrollment, and other information not required by the IHS regulations or the IHS handbook to get PRC services. Those who were unable to produce this information either went without care or obtained care on their own and faced collection agencies when IHS refused to pay for the services. If IHS did approve PRC services, there was no way to predict if IHS would pay the provider. When IHS does not pay PRC providers, the providers will assign the debt to third-party debt collectors and pursue tribal members for payment. Even though the Indian Healthcare Improvement Act generally states that individuals are not liable for bills associated with authorized PRC services. PRC providers rely on the boilerplate consent forms that they require all patients to sign as an alternative basis to pursue the debt. IHS's mismanagement of the PRC program has resulted in many Colville tribal members avoiding IHS care altogether out of fear of being saddled with medical bills and having their credit negatively affected. Near the end of our negotiations with IHS, we were shocked to learn that the Colville Service Unit had $42 million in carryover PRC funds. This money should have been spent on health care for Colville tribal members had IHS administered our PRC program properly. Some tribal members have paid medical bills for PRC services out of pocket because they feared having their credit damaged by being sent to collection agencies. There's nothing in the law or regulations that prohibits IHS from reimbursing beneficiaries when they pay out of pocket. IHS, however, has indicated that it is unable to reimburse for reasons that they have never explained to the Colville tribes. The PRC Improvement Act would clarify that individuals that receive PRC care that is authorized by IHS shall not be liable to any provider or debt collector. The bill would also preempt the use of boilerplate consent forms that providers require patients to sign from being used to target tribal members through collection agencies. Finally, S699 would require IHS to reimburse tribal members who paid medical bills for IHS authorized PRC services within 30 days. This is only fair because PRC bills are IHS obligations and tribal members should be made whole when they pay out of their own pockets to avoid collection activities through no fault of their own. For those tribal members who paid a medical bill out of pocket, the money that IHS would reimburse would be in the PRC carryover funds for that service unit. In other words, the reimbursement requirement would not cost taxpayers anything because that money is sitting in the IHS system as unreconciled PRC funds. For Colville tribal members, any amounts they paid out of pocket would be reflected in the $42 million carryover at the Colville Service Unit that I mentioned earlier. The Colville Tribes urges the committee to take whatever steps are necessary to secure the enactment of S-699 into law. And the Colville Tribes also fully supports S-1055, Indian Health Service Emergency Claims Priority Act, extending the time frame from 72 hours to 15 days for reporting PRC emergency care services to IHS. This will minimize instances of PRC care being denied for emergency care. This concludes my testimony, and I'm happy to answer any questions that the committee may have. Thank you.
Thank you so much, Ms. Seymour, and thank you for the very concrete examples you've provided the committee. And next we go to Ms. Leandra Ross. Welcome.
Wasayiti, good afternoon. My name is Leandra Ross, and I am the Vice President of Executive and Tribal Services at South Central Foundation. I'm a Tlingit and Haida citizen and a Salamatoff tribal member. I want to thank the committee and Chairwoman Murkowski and Vice Chairman Schatz for the opportunity to testify today and for your work on behalf of tribes, tribal organizations, and Alaska Native and American Indian people all around the country. Gunashchish. I also want to thank the staff that have been so helpful working on S-2098. South Central Foundation, or SCF, is the Alaska Native Tribal Health Organization under the Tribal Authority of SERI and designated by 12 federally recognized tribes. We provide healthcare services to beneficiaries of the IHS who we refer to as customer owners, as we're both customers and owners of our own healthcare. SCF is one of the largest employers in Alaska, with 3,000 employees that support the physical, mental, emotional, and spiritual wellness of over 70,000 customer owners, including residents of 55 rural villages in a service area that's over 100,000 square miles. SCF has over 850,000 unique encounters a year with 90-plus programs and is a model of how self-determination is successful in providing quality health care. Today, I'm here to testify on the South Central Foundation Land Transfer Act. This bill will transfer the title of land that the IHS currently owns and on which SCF operates the Koyana Clubhouse. This land transfer is necessary for SCF to build a new 44,000 square foot building for two critical programs. The buildings we are using now for the Koyana Clubhouse are some of the oldest the IHS has in Alaska and were not built to provide direct services to customer owners. In fact, the space currently used as an arts room was the old IHS hospital morgue. With the new building, we'll be able to expand services to some of Anchorage's most vulnerable individuals who experience chronic mental illness and adults with complex behavioral health and substance misuse needs. The Koyana Clubhouse, operating for more than 30 years, is an answer to the ongoing needs of adults with chronic mental illness to live a stable, healthy, supportive life in community. Koyana Clubhouse is a day treatment program that blends integrated behavioral health and primary care services to further meet individualized treatment goals done through the provision of support, including medication and case management, individual and group therapy, and cultural and wellness activities. Today, SCF has 114 customer owners in the program. The success of Koyana Clubhouse is evidenced by the fact that all participants are living in stable housing. In Anchorage, where sadly many Alaska Native people are unhoused, it is remarkable that with supportive services such as those offered at Koyana Clubhouse, customer owners can overcome this hurdle. I'm also pleased to share that 8 customer owners currently participating in the program have achieved their goal of employment. We're proud to support Koyana Clubhouse participants with over 87% reporting ownership in their own health care, some of which are Alaska Native veterans. The new building will not only double the capacity, but it will allow us to align and co-locate SCF's intensive case management services into the same building. The ICM program is a community-based program focusing on outreach, engagement, intensive community case management, and linkages to other critical services, such as housing, that assist individuals to increase their level of independence and develop a community support network. Think of ICM as one precursor to participating in the Koyana Clubhouse. ICM works with customer owners where they're at, whether that's in a homeless camp or living with family members, to grow on their journey towards wellness. S2098 will make possible the expansion of both programs in a state-of-the-art facility by giving SCF ownership of the land to build the building needed for our customer owners. SCF is ready to take advantage of the short building season and begin this project this summer with passage of this bill. To that end, we hope that the transfer can happen expeditiously. Again, Gunashish, thank you for the opportunity to testify today, and I'm also happy to answer any questions that you may have.
Thank you, Ms. Ross. Let me begin with you, Leandra, about the South Central Foundation Land Transfer Act. You have shared with the committee the current conditions of the Koyana Clubhouse. We understand that. Can you just share what the challenges are then with maintaining or upgrading the facilities when South Central does not own the land or facilities? And then I'd also ask you to give a little more clarity to what you just said at the end, which was you're prepared to move quickly, and if you could just describe what quickly means in terms of your ability to move should this land conveyance happen.
Thank you, Chairwoman. I appreciate the question. Thank you. The Koyana Clubhouse is in a 50-year-old building, and it has many of the challenges, as you can imagine, that 3 closely connected buildings would have. Heating systems are difficult to maintain. There's just participants walk outside to get to the different services located on the facility. This facility is one that we would love to see increase for our customer owners. We'd love to be able to build this summer. We are at currently a 35% design for the building. We're ready to build, and it will.
So if I can just ask on that, you're ready to build 35% design, but the thing that is holding you back is you do not have the warranty title.
Right. We do not have ownership to the land. Yes. And so we just would like the ownership through this land transfer to be able to build.
And if that is to come through this conveyance, you are prepared to move to start construction this year.
We're excited.
I can tell you're excited,
Yes.
and rightly so, and I know that those who serve are probably equally excited. And the importance in terms of being able to be more responsive for the increasing demand for behavioral health services in this area, I think is so important. So I just wanted to make it clear for the record that you are ready to go. The only thing that is holding you up is the full ownership of the property itself. And that, let me ask one other question, because it's always important that you have stakeholder buy-in,
Yes.
whether it's from the community. Can you just speak to the efforts to work with local stakeholders to prepare for the land transfer?
Yes, thank you. Good question. We have many partners, and the community in the area is very excited about the new building. We've gone to community councils. We've shared with the municipality our plans to move forward. We have letters of support from community partners. And I think that we've been a good neighbor in this area, and so we'll continue to be a good neighbor in this area.
Good, I appreciate that.
Thank you.
Let me ask you, Mr. LaRoche, because you have mentioned that, well, you support the conveyance. You noted a concern here. Congress has already passed several bills transferring federal land to tribal health organizations. In 2022, we were able to pass legislation that conveyed IHS land to the tribal Tanana Tribal Council, TCC, to the Southeast Alaska Regional Health Consortium, as well as ANTHC. So you've mentioned that you have some concerns, but can you tell the committee, when IHS carried out these transfers 3 years ago now, back in 2022, did the agency have any administrative difficulties in executing on them?
Thank you for that question. No, we had not had any administrative problems with that. We prefer the quitclaim, but
Sure.
But we enacted in law. We will go through with the warranty deed.
So I just want to make clear then, well, we get what the preference is, even though you didn't have that preference with these other transfers. The agency didn't encounter any difficulties then with that legislation.
No, Senator.
With how the deeds were titled. Okay. Let me move to you, Ms. Seymour. You have shared a great deal in your testimony today. The issues when you have PRC payment delays leading to these unexpected bills, medical debt, credit score impact, and you went further to say that in an effort to perhaps avoid this, you actually have some of your Colville tribal members avoid seeking medical care altogether, which is absolutely the wrong direction for any of this. So you made a decision. You made a decision back in October of 2025 to assume all IHS functions through a 638 agreement. To what extent did these concerns that you have raised, people who were fearful of debt collection issues and thus delaying perhaps medical care or treatment. You have also just detailed how this concern about what it's going to mean to me when I have the bills coming to my house. I'm dealing with a bureaucracy that I may or may not be very comfortable dealing with. To what extent did these debt collection issues affect the decision to contract IHS functions and take on the management and the provision of healthcare services yourself?
It had a huge impact on that decision. We were getting complaints, we were losing our people because they were not getting the care that they needed in a timely manner or not at all. And I believe the council has been looking at it for years and finally took the stance of, you know what, we can do better. We can, if we contract this and bring this under our supervision, we can provide our members with the health care that's needed. But like in the statement, it says we can trace this back to deaths in our communities. I can give you one example of some issues. I had a family member who was awaiting a specialist referral, and her appointment, I believe, had to be canceled. She was going to have the follow-up that Monday. She died over the weekend of a massive heart attack because she couldn't get to the doctor soon enough to be checked out. And she wasn't the only one. There were many instances where that happened on our reservation, and we decided that, you know what, enough is enough. We can't continue to lose our people. So that's why we made the decision to contract. Not only that, but also I myself have been sent to collections. I have bills. My husband has bills right now that are in collections. My daughter does because, and we diligently turn them in time after time, but they weren't being taken care of. And so what do? You don't want your credit to be affected. So if you have the means, you pay it. And a lot of our patients are elderly, and they were paying these bills out of pocket when they couldn't afford to do so.
So even though we've heard Mr. LaRoche say, look, the patient is not going to be liable, that reimbursement comes, you still have a situation where the debt collector is the one that comes before the reimbursement comes. And so there's concern about whether or not the reimbursement is going to be made, whether it's going to be made timely. Mr. LaRoche, you said something about, on this issue of reimbursement, that it's reimbursed to the extent of the PRC, and that the patient should be cautious in not exceeding the amount of the PRC. How do I know what that amount is?
And that's a great question. It would have to do with whatever that service is that they were sent out for, as far as usually the PRC program is paying providers, so that's what we're used to doing. So
Right.
yes, the patient wouldn't necessarily know what that reimbursement
and
rate
that's,
is.
You know, that's the heartburn that I've got with all of this, is you're putting the burden on the patient. If I'm going to go in for a mammogram, all right, and I don't necessarily check to see if the cost for that procedure in the area that I'm in is within the scope of what is approved within the PRC, and you're saying, all right, you're not going to be on the hook ultimately, but it could be a situation where we don't know how long that reimbursement is going to take, and in the meantime, who knows, it gets sent to a debt collector, we don't know. But then you find out that not the full amount is going to be covered, and it just seems to me that we are doing a huge disservice if we're saying there is a federal trust responsibility here when we're talking about health care for Native peoples, and you've got a program that for reimbursement for care that assumes an awful lot that is not very clear. You're nodding that you don't disagree that this is confusing to the patient. Do you have any good suggestions as to how within the department this can be addressed? I think that perhaps Senator Round's two bills could be very, very helpful to that.
Definitely. The PRC program in IHS has always been set up to deal directly from IHS to a provider, so that's why it's a little bit more confusing when we start talking about a patient having to pay on that. But I think this is an opportunity for us we'll be more than happy to work with the committee and the drafters to come up with some technical assistance and come up with a solution on that.
Okay. Ms. LaRoche made the observation that there's nothing in statute or regulation that prohibits reimbursement. CBO apparently thinks that there is some budget authority that is required. this is something that, again, I think needs to be made much more clear than we currently have in statute. Is that, we're in agreement on that? I'm going to ask my last questions, and I'm going to turn to my colleagues who have just come back because they've done their second vote and I have not. You have mentioned the issues that the burden of a 72-hour window creates. Senator Rounds had mentioned that as well. Do you think that people understand that this 72-hour reporting issue is a problem for them, or is that just an issue with the providers themselves? Yes, please, thank you.
So it's an issue for, I don't think everybody understands, and I think that's where it would be helpful for more education to the patient. But I think it's very cumbersome, like Senator Rounds had said, because if you have somebody who is in an accident and they're in ICU for 2 weeks, that you're limited to a 72-hour, but within those first 72 hours, your family is so focused on if you're going to live or not. The last thing on their mind is calling IHS to report to the PRC department that they're in the ER. And at that point, you don't know if they're going to stay at that hospital or be shipped to another. And then there's repeated calls that have to be made. So I think the 15 days would give a lot more grace time for the families and for the patients, because I think the first 72 hours of any illness is critical to taking care of yourself or your family member who's in the critical illness and in that time frame. But I think part of it is that patients don't quite understand that, and so it doesn't get reported, and then they get released from the hospital, say it's in 4 days, and then they call and then it's too late. So now they're stuck with this astronomical, ER or hospital stay bill that they have. Because attached to those bills also, like we're in a rural area, so if you get life flighted or ambulance, that's attached to that bill as well too. So if you don't report that, I mean, that could be $200,000 to $400,000 depending on where you're flown to. So.
And Senator Cantwell, we'll turn to you, and then Senator Lujan after that. I think Senator Schatz is coming back. I'm going to go vote. But I think Senator Rounds has presented a couple really strong bills on how we can improve purchased and referred care. But we've heard some really very interesting testimony here today in terms of how a system that that should work better, that should ensure that Native American patients, when they go to seek care, are not ultimately on the hook, but it's some pretty troubling stories. So I think we've got some good suggestions out there, and then Ms. Ross from South Central Foundation working on great initiatives when it comes to the opportunities for access for mental and behavioral health. So I'm going to turn it to Senator Cantwell next, and
Thank you, Chair Murkowski. Thank you for you and Vice Chair Schatz for holding this legislative hearing. And the chair just mentioned Senate Bill 699, the Purchase and Referred Care Improvement Act. I was glad to join Senator Rounds on that. I want to thank Councilmember Seymour for traveling all the way from Colville to be here in Northeast Washington. So very challenging to get all the way across the country, particularly. We just had some people in the office from Oroville, and I was like, how'd you get here? So everybody, a lot of traveling this week. So I teamed up with Senator Rounds because introducing this Purchase Referred Care Improvement Act really after hearing from the Colville tribe. I mean, it was just really clear the pervasive problems. If you're in this rural part of the state and IHS is supposed to deliver care, but IHS doesn't deliver care, and then your people end up getting credit score deterioration, how are you supposed to get health care? And it's all because Indian Health Services was not paying its bills. So as we already heard from the council member, the Colville Reservation, which encompasses 1.4 million acres, so no small area of geographic area to serve in the northeast corner of our state, there are no full-service IHS hospitals and a 60% vacancy rate at Colville IHS service unit. Now, that's basically abdication of duty, if you ask me. It's just abdicating the duty that we are supposed to provide for health care. This means tribal members often travel long distances to seek the health care providers outside of the IHS system. And the IHS system is supposed to reimburse the healthcare provider for those services provided to those tribal members. Unfortunately, when this doesn't happen, IHS does not reimburse the healthcare provider, and then the provider is not paid, and then they seek payment from the tribal members. So that's what we're here to try to say. It's got to stop. It's got to stop. We can't be putting this on the backs of individual tribal members. This is crazy. Live up to our responsibilities in delivering care, either through the IHS system, or let us go get care and pay for it. That's the role and responsibility here of the federal government. So tribal members, including elders and elected officials, have been sent to collection debt creditors. So literally, we're not providing the health care, but then we're letting debt collectors prey on individuals. So the Colville tribe recently learned that there was a $42 million in funds that should have been spent on health care for tribal members if only IHS had administered the program properly. Recently, the Colville tribe assumed all IHS functions under the Self-Determination Act. And I must say, I'm so proud of our state where we have become the primary provider under self-governance of clinics around the state of Washington. Not only are they great tribal clinics, they are serving the larger population within a region. Oftentimes, they're in some of our remote parts of our state, like, the Macaw or the Lummi or something of that nature. And not only are they providing great Indian health services, but they are providing care to the larger community and really becomes a stabilizing force for healthcare within the region. And obviously, Indian country, because it's been preyed on for the most egregious abuses of narcotics, with people locating big fentanyl centers. Why do they locate in Indian country? Well, I just said the vast land that basically is there at Colville or somewhere else is because you can't cover all that land. You can't cover all that tribal land. You can't cover, they know that tribal law enforcement is challenged to deliver and root them out. And so we've had horrific challenges just dealing with the attack on Indian country by the scourge of fentanyl. So, Councilmember Seymour, again, thank you so much for being here to illuminate this. I wanted to talk about how the Purchase and Referred Care Act does support Indian country. And since IHL's healthcare services, since the tribe has taken over and has your own relationships, are tribal members financially getting better protection?
So tribal members are financially better protected under the Colville Tribal Health Care Authority because our purchase referred care payments are issued faster and more reliably than under the IHS system, which is reducing delays, denials, and unexpected patient bills. We're also able to build and maintain financial reserves for our programs, which strengthens long-term sustainability and protects services during funding challenges or emergencies. So that, combined with stronger revenue cycle oversight and local decision-making, tribal control has shifted financial risk away from our members and towards a more accountable and sustainable healthcare system.
Thank you. Thank you for that leadership that Colville is demonstrated. And again, if we can just continue to empower, I think through self-governance, the delivery of a system, I think we're going to get a better system. But on this issue, Mr. LaRoche, is there any legal impediments to IHS reimbursing tribal members who pay PRC bills out of pocket so that they can stop being harassed by collection agency? Is there any legal impediment to that?
Great question. I'd have to take that back to the legal, as far as from the legal side of things, but I do know one of the things that's challenging for us is we are bound by the federal acquisition regulations, and sometimes that's a little bit cumbersome for providing payments for health care and still complying with
Burdened
that.
by what?
The federal acquisition regulations, the FAR. It requires a purchase order, so it's a little bit more cumbersome when we'd have to really work with the tribes and IHS to come up with a mechanism to actually.
Okay, so
Hey.
why haven't we done that yet, is my question.
That's one of the things, if this is passed, we can go ahead and do that.
Why can't we do that
they-
right now? We know that we have a broken system in a big part of our state, and why can't we figure out, why can't IHS, if they're not gonna deliver the care? I mean, obviously, these are choices, right, that people made a long time ago. I'm assuming, I know lots of lawyers in the audience who know this, are back here on the dais, who know this better than I do, but, I mean, different parts of states made different choices, right? Whether through self-governance or IHS. But if IHS now can't deliver the care, and the tribe is now taking on the financial responsibility of delivering the care, and you have a direct relationship, I'm assuming, because you can't deliver the care at IHS, that you are then contracting with them. So if you're contracting with them, why can't you just protect them from being preyed upon by creditors?
The IHS PRC program was really set up for the payments between us and the providers. So that's one of the things, and we are working we do have a director's work group to improve PRC, and things like this have been talked about there, so we can take those suggestions.
I will get with you. You should go back, get an answer, and figure out why we can't do this sooner.
Okay.
All right. I'm not really chairing, but I'm passing on down to Senator Lujan. Senator Lujan.
Thank you, Senator Cantwell. Last year, IHS made the decision to move funding away from at least 2 New Mexico tribal health facility projects on IHS's list of facilities that need to be replaced. One is in Albuquerque. It's the Albuquerque West facility, a priority for Santa Ana Pueblo, and one serving the Navajo Nation in Gallup, which is one of IHS's largest facilities, serving a large portion of the Navajo Nation. Actions like this depriving the tribes of these funds creates uncertainty and hinders negotiations and planning. Worse, the tribes, the Pueblo and the Nation, had no explanation as to why the funds were moved, allowing them no opportunity to resolve any issues and maintain their funding. Last year, I met with the leadership of Santa Ana Pueblo, and they told me the Pueblo had broken ground on a new facility, and it is shovel-ready. I believe funding has been restored there and want to be sure that it will not be removed again. Mr. LaRush, yes or no, will you commit to prioritizing these projects and using the encouraged 638 authorities where possible?
Definitely, all of the facilities that are on our grandfathered list are our priorities, and we do encourage the 638.
Appreciate, and just to be clear, Mr. LaRush, both those projects are on that list.
Correct.
Appreciate that. Mr. LaRush, yes or no, will you commit to meaningful consultation with sovereign nations before IHS chooses to move their funds out of their projects?
We do realize that we do need to discuss that with them. I believe within that authority, or the funding authority or whatever, we were able to kind of move things around, but we do need to make sure that we contact and work with the tribes whenever something's done like that.
Are you comfortable with committing to meaningful consultation with these sovereign nations if that's a decision that IHS is making?
It will follow the tribal consultation policy.
I appreciate that. Just because when discuss versus meaningful consultation, as we know, two different things. So I very much appreciate that, Mr. LaRush. Lastly, Secretary Kennedy visited the Navajo Nation last year and specifically mentioned access to water as a priority. But just yesterday, there are signs that remain at the Gallup Indian Medical Center stating that the water in the hospital is not safe for human consumption. So there were letters, or there were signs that were up when the Secretary was in New Mexico. He didn't go, but I asked the same question. All of a sudden, those signs were taken down. Well, now there's new signs that are up. And the sign's different, so to the credit of the staff, they didn't put the same signs up if they were reprimanded for saying the water's not drinkable, but now it's a picture. And it says the water is for hand washing only. Now, the little bit that I know about water is when you can't drink it, you're not supposed to wash your hands with it either. It's a hospital. So my question, Mr. LaRuche, is when will IHS restore safe drinking water at the Gallup Indian Medical Center, and what is your plan to do so?
I don't have the details on that. I will need to go back to our Office of Environmental Health and Engineering and check on their plans. For
I appreciate. I'd like to hear back as soon as possible and see if you need authorities, if there, whatever is needed to work with my colleagues. If there are any IHS facilities in the country where it's a hospital, they don't have drinking water, I don't think there's going to be disagreement to say, no, they should have clean, safe drinking water. Mr. LaRuche, so I apologize. I said that. I told myself I was not going to say your name incorrectly today, sir. Mr. LaRuche, last week IHS announced it's launching a major hiring push to rebuild and strengthen the IHS workforce. I appreciate that, and this is welcome news, I think, by all of us. My question, though, is how do you plan to implement the hiring push and actually get health providers into facilities? Because I've heard from my constituents that they've been unable to hire staff because they face red tape and background checks that can take 6 to 9 months for some of these positions. Now, I appreciate saying that there's going to be a major push. My question to you is, what are you going to do to address the foundational issues that have held up hiring?
That's a great question. With bringing on over 3,000 people is our goal for this this next year. We have brought together our HR team as well as what you had mentioned as the other people who are involved with getting people on board and getting the recruiting and so forth. So we have had a meeting on that to approach it in a comprehensive way so that we can have all the parts of our organization ready for that big hiring.
Is it fair to say, Mr. LaRuche, that 6 to 9 month backlog, that timeline, that will be condensed? They'll look for inefficiencies in there, see what needs to be done to make sure that we're not losing healthcare providers when they're recruited. They say they want to go move there, and then they're told, well, in 9 months, you have a job.
We're definitely working on that
Yeah,
to reduce that
I
time
appreciate
frame,
that.
definitely.
What I'd be interested, sir, is if you could detail for me, and we could work with the teams, why the background checks are taking so long. So if there's things that we need to do together, that we look at that as well. And then what is the concrete problem that needs to be fixed to speed up the background checks? I'm very interested in that. There were a few providers that were identified for a few small facilities in New Mexico, and they lost them because of the 6 to 9 month delay. And they need a paycheck as well. They need to take care of their families, and they had other opportunities, even though they were ready to move. And so if there's something we could do there, I'd be very interested in working with you.
Thank you.
Yeah, thank you for that. With that, I recognize Senator Cortez Masto.
Thank you. Welcome to the panel members. Thank you very much. I do want to focus most of my questions on S1055, which is the Indian Health Service Emergency Claims Parity Act. Currently, Indian Health Services beneficiaries are required to notify the Purchased Referred Care, commonly known as PRC, the office within 72 hours of receiving outside care during a medical emergency. Now, the last thing patients should be thinking about during an emergency is having to file the paperwork to make sure their hospital visit is properly covered within the 72 hours of that emergency. So for me, and I think this is why Senator Rounds, I was so pleased that he introduced this legislation and I joined him on it. I think there's an opportunity here to make common sense here, right? So is there, this legislation that we introduced, the Emergency Claims Parity Act, it extends the reporting deadline for IHS patients who seek emergency care outside of those IHS facilities from 72 hours to 15 days. 15 days. Now, Deputy Director LaRuche, in your testimony, you indicated concerns over flexibility, noting that S1055 would limit the Indian Health Services authority to a period of 15 days. Are those concerns? Could you elaborate on the concerns?
I'll say that we do support the 15 days, but if what we're saying is if it is put into law, that if we ever wanted to even extend it longer than the 15 days, go to 21 days or something, that we'd have to come back and go through the federal process here.
Is there, and because for seniors and people with disabilities, they have 30 days.
Correct.
Is there a reason why we shouldn't look at 30 days just for everyone?
We could take that back for consideration.
But right now, you do support the legislation, the 15 days. Your only
Correct.
concern is the flexibility if you want to make it longer.
Longer, correct.
Okay, we might be able to work with that. Thank you. I appreciate that. That's very helpful. Let me ask you this. Yesterday, I introduced a piece of legislation, the Stronger Engagement for Indian Health Needs Act, again with Senator Rounds. This bill would elevate the director of IHS position to an assistant secretary at HHS, granting greater authority over recruitment, retention, and interagency coordination. In fact, Secretary Kennedy, in testimony at his nomination hearing before the Senate's Health, Education, Labor, and Pensions Committee, expressed support for this idea. It's not new. Senator John McCain previously introduced the bill, and it has passed the Senate before. Given the recent introduction on the bill, and I understand you probably need more time to review it and take it back, but I would just appreciate your review and your thoughts on it. Not now, but in the future, at any point in time. Obviously, it's not new legislation, but I think it is important, and I would love your feedback at some point in time. Would you be willing to work with me?
Thank you. Yes.
Great, thank you. At the end of the day, let me just say this. I think for many of us, particularly those that have Native American communities, tribal communities in our state, we got to do a better job of providing them opportunities for care for Indian health services. I hear it in my state. We're hearing the conversations and the concerns today on these three bills. Can I ask the other panel members, is there anything else that we should be aware of that we haven't addressed today that you would like to make us aware of concerning whether it's the bills that we heard or the concern just in health services in Indian country or Native American, Alaskan country as well?
So I think regarding the bills that you heard today, especially the PRC, the two PRC bills for us, is IHS looking at their PRC program as a whole, because the $42 million carryover that we had at the Colville Service Unit was I, as well as our other council and staff were there at the negotiations, were dumbfounded when we heard how much money was there. And it was very disheartening, because when you have people dying daily because they're not getting the health care that they need, and then you find out that IHS has been hoarding $42 million that could have sent them to get the care they needed, it's heartbreaking and gut-wrenching. So I think if that is something that can be looked into with the PRC program. I've worked for the PRC program myself earlier on in my career. I worked with a big part of the problem is the fiscal intermediary not paying the bills as well. We were using New Mexico Blue Cross Blue Shield, I believe, at the time as who we were going.
Not paying the bills, they were denying the claims, or just not
They
paying
just
them?
were not
Just
paying
not
them.
Denying
So,
everything, there's nothing
yeah.
that you could do that you've seen that?
They weren't paying them, and that's why they were getting sent to collection some of the time, was because the fiscal intermediary wasn't taken care of for whatever reason. And our staff at the local level tried to work with them, like, what can we do? What do you need? What documentation can we submit to get those bills paid? But it's just such a cumbersome process. So I think to help that process for others, we have our own FI now because we're contracting, but to help the other tribes that are still with IHS and their PRC, that would be something that I would recommend looking into.
Okay. Ms. Ross, anything else?
Thank you for the question. I would just add that the support of self-determination that tribes, tribal organizations have within them, the ability to manage their own programs and funds successfully, innovatively, and with quality. So just the support of expansion of self-determination.
Thank you. And thank you. And then Deputy Director, anything else that you would like to respond to that you heard today that we need to be aware of as well?
Again, supportive of the bills, and really looking forward to working with the tribe, South Central Foundation, and the tribes. And I will say our PRC program, we've been going through a lot of improvement efforts over the past couple of years to do exactly what was brought up here with working with the fiscal intermediary and trying to remedy those. So we're still working on that. So continuous improvement.
Thank you. Thank you all for being here.
Thank you, Senator. I just have a couple quick follow-ups here. Mr. LaRoche, you note in your testimony that IHS has seen what we're referring to as bad actors in the PRC space when it comes to private providers not following Section 222. The provision prohibiting them from seeking payment from a patient, and you also note that this legislation doesn't provide any mechanism for consequences. Has IHS taken any steps to end agreements with or otherwise discourage these bad actors?
Definitely where the bad actors have been identified, we have been working directly with them to go through and make sure that it's not just that they don't understand the process or they're looking for certain things that they're not receiving to be able to put those or get paid by other the other payers that may be involved and things like that. So we are working on that. So it always starts with working together with them and finding out what that problem is. But if there is anybody that's been egregious, we usually don't continue with them. But one of the challenges is sometimes those providers may be the only ones within a reasonable area. And then that ends up, we have to look for people kind of outside of a closer area.
That's not a good outcome. You keep somebody that you know has got a bad track record. That's not helping improve the system at all. So Ms. Seymour, it's my understanding that because of what we're seeing with IHS's poor management of the PRC program, you're actually seeing fewer local health providers who are willing to participate in the program. So to your point, Mr. LaRoche, you're saying you might not have anybody in the area, and then because you've got things that are poorly run, you have providers that say, no, I'm not interested in participating, or do you have non-IHS providers that have refused to perhaps schedule appointments with members that have unpaid prior balances from previous PRC claims? I mean, I look at this, and this situation just does not get any better. You're just making it harder to get access to care, even if it's bad with the provider situation.
So from Colville's perspective, we have seen providers who have canceled contracts with us because they haven't gotten paid. We've had patients go to their appointments and not be able to be seen because they don't have a purchase order or they have an outstanding bill that wasn't paid.
So on that last point, so if I'm that person and I have an outstanding balance, if I have a condition that I need to be seen for now, am I flagged because I have this unpaid prior balance? So I go in, I check in for an appointment, and I'm told, sorry, we can't see you for this appointment?
Yeah, basically that's what has happened. And sadly, we've even had people turned away for cancer treatments and oxygen and different things like that because they have outstanding bills.
And so the only alternative for me in that situation would be to say, well, I'll just pay out of pocket?
Yeah, basically some of them, if they have the means, will
Yeah.
make a payment at that time so they can be seen. And that's how we end up in this situation is, they should be reimbursed, but IHS won't tell us why, but that they can't. They just keep saying they can't reimburse patients. But some of them, like I said, are elders, or we live in a high poverty area. So most of the people that we provide services to can't afford to take $100 out of their pocket to pay on a medical bill so that they can be seen by their provider that day.
So you last year, so you're not even 6 months into your 638 agreement here. Are you hearing from those who are part of Colville Tribe that the situation is better now? Do they know that they're not going to be turned away at their appointment because of unpaid prior balance with it? I guess I want to know whether or not you have seen improvements because of the direction that you've taken.
We have seen improvements, and some of that has come from patient communication, but it's also came from our staff who are initiating the payments and making sure that the payments are being paid timely. They've worked diligently to make sure that they're establishing contracts with all the providers we use, communicating with the providers so they know the process that they need to follow to make sure that we get payment taken care of. And
Are you seeing more providers that are perhaps now interested in?
yes,
in
we've actually
offering
had
care?
providers reach out to us to say, hey, we would love to work with you guys, who had previously canceled due to IHS non-payment. But now that they're hearing that we have our Colville Tribal Healthcare Authority administering that program, they're more willing to work with us because they trust that they will get paid.
And I think this is where you really see self-determination play out in a way that is meaningful, provides for that balance and those true results. And I think just having Ms. Ross from South Central Foundation on the panel here today is an example of what you really can do when it comes to tribal health organizations coming together and working to meet the needs of folks where they are, not being as directed or controlled by operations 4,000 miles away. But I think we see very strong examples where not only are we talking about those principles of self-determination, but we're seeing them in action. And, you know, my hope is that those in the Colville Business Council are going to see positive results as you assume this direction. And to you, Mr. LaRoche, I think you've heard some really good examples of the challenges that are being faced. We've talked about this in this committee for a long time, and I'm in a different situation than my colleague in South Dakota, and I'm very proud of what Alaska Natives have come together to develop through our tribal health organizations. In many ways, we're leading the model when it comes to healthcare delivery, and that's exciting. But to know that so many in Indian country are struggling with a system that is clearly not working for them, and in many ways is just punitive on many different levels. When you are choosing to not access care because you're fearful that you don't know how this whole reimbursement process is going to work, or if it's going to be reimbursed, or if you're going to get sent to the debt collector. It's not a place that we should be. So I'm really thankful that the committee is going to engage in these legislative initiatives, and look forward to working with colleagues to help advance them, as well as with the department. And I think I'm reading body language here, and you have not given me serious frowns or no. You're kind of acknowledging some of the deficiencies, the real deficiencies within the department, and an acknowledgement that we need to address them. So look forward to doing that. And with that, the committee stands adjourned. We'll be taking testimony or questions for the record for 2 weeks after this. Thank you.